Good morning, everyone. I'm Jill Chadwick, and I'm sitting here, and you know what that means. That means that Dr. Stephen Stites got called away again. We're here in the Dolph C. Simons Jr. Family Broadcast Studio. I did want to stumble just like he does over the name because I wanted people
like
at
him.
home, to feel more comfortable. Before I say my next thing, here's what I need from you at home. When I have to sit here suddenly, that means somebody else is doing my job. So I really need the community to come up with great questions today. Make that job easier for Jessica Lovell, who is now Jill Chadwick this morning. All right. In studio with us is Jodi Schmidt. She's Executive Director of the CARE Collaborative. And joining us virtually from the western edge of the scenic Flint Hills is Austin Gillard. He is CEO of the Clay County Medical Center. And from the heart of Kansas, Chief Nursing Officer at McPherson Hospital, Beth Worden. So good to see you guys. Thank you for being with us. These guests today are going to help us share the story of COVID-19 in Greater Kansas and the response that has been mounted by the CARE Collaborative, which is a statewide clinically integrated network sponsored by the health system, and it connects hospitals and physicians and providers in 66 counties. Really impressive. Let's talk about another number. Dr. Hawkinson, how are we doing this morning?
Yeah, well, I think we're doing pretty good. We have to remember that Dr. Stites does have a full-time job as CMO and also seeing patients, so sometimes that gets pretty hectic.
That doctor thing, it really does.
Making patients better. So today our numbers are pretty good. We have 20 in the hospital, so I think we are really reaching that equilibrium of 20 to 30 right now. Hopefully it won't go up. Obviously we'd like it to go down. We do have 5 in the ICU, so that's 1 more than yesterday, and we have now 2 on the ventilator compared to yesterday. So we did get a critically ill admission, but we also have 35 other patients in the hospital who are recovering, who are out of the acute stage of COVID-19. But again, are still in the hospital because of COVID. So.
And of those 35, are there any that are still on ventilators?
There are 4 that are still on the ventilator. Yep.
It's really hard to come off the vent sometimes, isn't it?
Yeah, it is. It certainly is. And that is something that we have seen from the first patients that were in the United States and the first patients that we had here. It typically does take around 10 to 14 days. Obviously, sometimes it can be longer than that, too. So.
All right. Well, we thank you for that update. Don't go anywhere.
I'll be right here.
Okay. Jodi, let's start with you. Tell us a little bit about what, for people who may not know, what the collaborative is and how it got started.
We started a little over 5 years ago with the goal of connecting the resources and expertise here at the Academic Medical Center with rural providers all across the state. I was a former rural hospital CEO myself before joining the health system, and I can tell you it's a real challenge to stay on top of all of the latest research and evidence-based practice. And so our goal is to bring those resources out into the rural community through protocols and guidelines and localized trainings and support and ongoing education programs. And when research indicates a new opportunity to care for heart attack or stroke or sepsis patients, then we can bring that to our members in a matter of months instead of years, which is typically what happens around the country. And so from that, as the pandemic hit, and we were just getting ready to launch new programs in trauma and palliative care, we said, how can we take that experience and really bring it to bear in this example? And so we've taken the protocols and the recommendations developed here and made them fit for a rural environment and then shared it with our members all across the state. We've worked with the Hospital Association to do weekly clinician calls with Dr. Hawkinson and others, and really done the best that we could to make certain that the information we had as it was coming in, like drinking from a fire hose in the early days, so much information, so much to process. Our members said some of them said we came to the point where there were 2 sources of truth for us, KDHE and the CARE Collaborative. And that really told us that the work we were doing was making a difference, making it just a little easier for our members.
I think it's a great story, and I know that in these rural areas, because I grew up in a rural community too, right? And your hospitals are essential, and you know the people that are working there, and they do great work. And I think that everybody that's listening to learn that you have a collaborative where all the oars are in the water and everybody's rowing together. I mean, that's what we think healthcare is supposed to be as a society, right?
Absolutely.
Everyone
where we
working.
can. What's been wonderful about our opportunity when we can go on site and do boot camps is we're inviting all the providers at the local level, physicians, nurses, EMS, long-term care, all the support people, so that everyone's coming together with the same information at the same time. And we have found that that makes all the difference in the world. But through COVID, we've been doing that virtually.
Yeah, well, let's turn to our guests because we want to hear about their communities, about healthcare, and if they are experiencing COVID, how it has changed the work that they are doing and how they are serving their patients and community. We're going to start with Austin.
Okay. Well, just a little update on what's going on in Clay Center, Kansas, and Clay County in general. COVID's had a dramatic impact, not only on the urban healthcare centers, but also in rural America, such as Clay Center, Kansas. So to date, there's only been 40 positive cases within Clay County, but our hospital and our staff have taken this very serious since mid-February. So visitor restrictions, everyone's masked up, and thanks to the University of Kansas Health System and the Care Collaborative, we get a lot of great information from your team and also from KDHE on proper PPE recommendations, how to isolate our patients. Do they need to be in a pure isolation room, which we only have 2 of in our entire system, or can we put them into a negative airflow room, which we've developed over the last several months. But visitor restrictions have been pretty hard on our small community. Like you mentioned earlier, Jill, a lot of our patients and employees and community members are really tight-knit. And so when that loved one's in the hospital and they can't see that patient for that illness that they're admitted for, it's been pretty difficult emotionally on our community. But overall, COVID's impacted our everyday life, even in rural America.
Wow, what an update. Beth, what's the story there?
Well, I'm beginning to think that Clay and I are in the same hospital because what he has said is exactly what we are experiencing. We have a total of 227 confirmed cases here in our county. We've had a total of 8 patients in our facility. Right now, we have 1 patient. We have made a COVID unit, which we house them in. And we have been so fortunate, as Clay said too, to look at evidence-based practice and know that we have KDHE and the collaborative right there. We watch them daily, sometimes multiple times a day, to see what is happening. What are they recommending? Sometimes we change, PPE recommendations every 2 days or every 3 days, but it's reassuring to know that it's evidence-based practice. We're doing the best thing we know right now. We say we have no visitors in our facility. We call them a support person. At first, we didn't have anybody coming, and we found, in these rural areas, we have a lot of elderly people. Sometimes there's some dementia involved. It's just the anxiety and the stress that they experience when they come into our hospital that sometimes they don't know the answers. And we found it was a safety issue. We needed a support person there for them. So we say we don't have visitors, but we allow 1 support person to come in full mask. We check their temperatures every day. We ask them if they have any symptoms. And then we do let them come in. Once they've come in, we ask them not to leave. And that has helped our community, knowing there's 1 person that can stay with that patient in the hospital. About the first week and a half or 2 weeks, we didn't allow anyone in, and that was very hard. And it's hard for healthcare workers because we don't communicate the way we used to, and that's difficult. We communicate in mass. You have go-to meetings. You don't physically see your peers. And we always know that communication is at the heart of every error that happens in the hospital. So we have really concentrated on safety at this time. And it is so good to have the KU Collaborative and KDHE. That is our source of information. And I get phone calls probably a couple times a week saying, hey, what are we supposed to do? And I just quote them. This is what KDHE says. This is what the collaborative at KU, this is what KU is doing. We are practicing the same medicine that they do at KU. That's very reassuring to our physicians also.
That is a great update, and I'm glad you brought up the thing about communication, because I always like every opportunity to tell people at home, you know, when this started and we all had to put masks on, I think that was the hardest thing when it came to communicating. Medical professionals maybe are more used to talking with a mask on and communicating, and you're close by so you can, you know, make sure that you're being well heard or well understood. But over virtual, like we're doing now, and having a mask, I used to tease, I can make people say anything I want them to, because you can't tell when you have that in front of your face. How is the mask culture? And here we've measured and we went to a lot of lengths to make sure that that we're safe even while we're talking in this moment without our masks. But we all, as Dr. Seitz shows, we all have our masks very close at hand. How is the masking culture in your communities, Austin and Beth? Let's start with Austin.
Okay, so within the facility and our employees definitely understand the importance of masks. It's still not mandated within Clay County. The commissioners and the mayor and Clay Center haven't mandated it, but most people are taking it very seriously and wearing masks in establishments when they go to the grocery store, the hardware store. So, you know, there's a few naysayers, but that's to be expected. But overall, people are taking it very seriously.
Mask
I think I could say the very same. The majority of people, we don't have an issue when they come in. They don't like it, but you know, it's the new norm. And I think they've all accepted it. We as healthcare workers have to be the mentors, and people have to look at us to say, what are they doing? So when we go to the grocery store, we go out in town, we want to have a mask on because we want people to look at them and say, oh, that's what they're doing. That must be what we should do.
Exactly. My sister and I have talked about masks and hand sanitizer are going to be the new stocking stuffers at Christmas. I want to hear a success story or a couple of success stories from all of you real quickly, and then we're going to open it up for questions. So, Jodi, I'll start with you. Give me a success story or two with a collaborative, COVID or non-COVID related.
Sure. We have a team of 11 healthcare coaches, and they work with Medicare patients who have multiple chronic conditions, and they have done some remarkable work really providing that additional support that folks have needed where perhaps a business is closed and someone's about to lose the roof over their head, finding them the support they needed to make sure that they could be safe and secure and not moving into a tent in the summer heat, which was literally one of those options. For other patients that had been, I'm high risk, but a member of my family has now tested positive. How do I quarantine? What sort of support did I need when all the clinics went to telehealth? How did I, as an elderly patient, understand how to connect in to my provider via telehealth? And how did we coordinate transportation when everything reopened? So a lot of really great success stories from our coaches around those one-on-one patient needs that are so very important when things are changing so rapidly.
Tell the story real quick that you were telling me before we began. It's not always necessarily like getting a prescription or being hospitalized. You were telling the story of someone who was about to lose their home.
Yes, absolutely. It's those very real life things that our health coaches deal with. An individual who has lost their ability to afford the place that they live and really needed an option. You know, someone in their 70s can't be living in a tent in the summer heat. I mean, those are just not things that can happen and should happen and were a consequence of the pandemic. And so the team really has done this amazing job of really managing all of the information that's coming in about how to help folks and how to coordinate and how to step up. And because they have a long-term relationship with these patients, they connect in with them month in and month out. They're the person that they could call and get reassurance and get good, solid guidance and really help them understand how to make the best of a tough situation.
Jodi, have you got, or I mean, Beth, I'm sorry, I don't know why you're Jodi. Beth, Beth, have you got a story that comes to mind that you'd like to share?
Well, I have a couple of them. I was trying to decide which one was the most interesting, but one of them actually has happened recently where we had a husband-wife team that one came in a couple hours earlier than the other did. And they're elderly. They try to care for each other, and they weren't caring. They were unable to actually care for each other, but that was their hope. That was their wish. So we put both of them in the COVID unit. They were right next to each other. They could converse. There was a few days that they were ill, very ill, and thank God for remdesivir. We hadn't had it until just a couple weeks ago, and now we have enough that we can use it, and we used it on both of those patients. But one of them was able to go home before the other one was, and they were each other's durable power of attorney. And I don't want anyone to identify these people when you're in a small community. You know, everyone can identify each other. So anyway, I will just say that one went home and said, you know, I can bring the other one home and care for them. We said, oh, it's not a safe environment. You really shouldn't. They absolutely insisted. And we said, health-wise, she could probably go. She had recovered quite well, but you never know when these people are going to have a setback. So you really watch closely for when all of a sudden their SpO2 drops, their chest x-ray looks worse, they're having a more difficult time. And so we said, okay, you know, we can't hold you here against your will. Went home. Within a day and a half, this patient was picked up again by our EMS. Brought them back. They really did not have medical reasons to stay at our facility. And I guess one of the things I thank the KU Collaborative for is helping us and helping nursing homes to say, yes, you can take these patients. And right now, nursing homes are very anxious, and I don't blame them. They have every right to be as protective as possible. But we could not get this person into a nursing home. So when this patient came back in, we took them in. Thank goodness for swing bed. We put them in a swing bed, and I think we're going to actually get them to a nursing home based on some of the information that we have received from the KU Collaborative.
That's awesome. Great story. Austin, you got a quick one before we go to questions?
Yeah, so this is just about the Care Collaborative and what's happened at Clay County Medical Center and a lot of the other facilities that we've contracted with the collaborative. But we really focused on cardiac, stroke, and sepsis patients. And just over the last, from 2017 to 2019, in the Care Collaborative alone for mortality rates with cardiac and stroke patients, we've moved that measure from 9.9% of patients passing away in our facilities to around 2.6 in 2019. And then on the sepsis side, just at Clay County Medical Center, just being able to detect sepsis a little sooner. In 2017, we were at a 12% mortality rate, and in 2019, we were at 0%. So again, we just think the best practice of the KU Collaborative helping our rural communities achieve those kind of rates.
That's awesome. It takes everybody for sure. All right, let's open it up for questions, and we start with media.
Yeah, Shane from KCTV5 wants to know, we know that younger people are spreading COVID-19 more and more right now. What are your thoughts on haunted houses opening up this Friday night? Do these have the potential to be super spreader events? And do they present difficulties with contact tracing?
Yeah. Yeah, you know, I think the answer to those questions are yes. We have to understand, when we're talking about haunted houses, we need to understand the clients or the customers who come, so it needs to be safe for them. Certainly if you can spread the line out as far as possible so that those parties or those groups of people that come together can be separated from other people. So that's the distance. Absolutely everybody needs to be wearing masks. In the haunted house itself and with the employees, everybody should be wearing masks. If you can wear a mask underneath the Halloween mask, that would be great. If you don't have Halloween masks but are using makeup, certainly everybody needs to have at least that cloth face mask on to help prevent the spread. Obviously in the haunted houses, a lot of people are going to be yelling, so that can express a lot of virus into the air. Although the actual time of contact from a customer to an employee is going to be probably short, probably very transient. Again, you will have people yelling and screaming. That will express more virus into that immediate area. So certainly masking is going to be vitally important. Anything you can do to spread out the amount or the groups of people so that their distance from each other is better is going to help as well. And if you can continue to take those precautions, that will reduce the risk of spread of the disease. But again, it comes down to the individual clients and customers doing those things as well as the employees.
What about eye protection?
Eye protection, we've always endorsed eye protection. Certainly if you can wear face shields, whether you are the customer or the employee, that's going to be good. And again, any other eye protection you can buy from the hardware store, safety goggles, anything like that will help as well. It may be more advantageous for the employees, as the employees are going to be in that haunted house for that prolonged period of time. So,
all right. Do we have any media on the line that have questions? All right. Any other questions from media?
Nope, we got
that's
some
it?
from the public. So
All right.
Angela wants to know, when is it safe to assume that you have not contracted COVID if you were masked in a home with someone who was symptomatic, not necessarily had it, but maybe had symptoms of it, but they were socially distanced?
Yeah. I think that's a good question. I think that goes back to the 14-day quarantine period that we talk about. It's at that 14 days, if you haven't had symptoms, then you are okay to come out of quarantine. You can certainly test, but testing does not get you out of quarantine. There is no good guidance for testing. Some people have posited that maybe testing at 5 to 7 days, but even if you're negative then, that doesn't mean you can negate the 14-day quarantine. We have had people here who developed symptoms at 12 days, so even if they would have tested at 5 or 7 days, we would have missed it. So that 14-day quarantine period is very important for that fact. We know the incubation period, for the most part, for people can be up to 14 days, and that's why it is so important, not necessarily to test, but to maintain that 14-day quarantine.
All right.
So on the topic of masking culture, Ashley said Johnson County is meeting today to debate the masking policies. What is the panel's thoughts on that in general?
All right.
Yeah.
I'll start with you, Dr.
Yeah,
Atkinson.
I think the medical evidence is quite clear that masks, as well as distance, do help. We know that businesses around the nation and around our community have closed down. We want these businesses to thrive. We want people to be able to work. And the way to get back to doing that is by having the masking. We know that there is very good evidence for spread in small areas, indoor areas, and those would include restaurants and bars. We know that places that have closed down in-person dining are doing much better as far as spread of the disease compared to other cities or communities which have allowed in-person dining. So if we want to continue to be able to go to restaurants, to have our businesses open, the masking is vitally important to keep those places in business, to keep those employees working, and to keep food on their table.
Austin, you said that you don't have a mandate where you are, but people are still wearing the masks.
That's correct. Yeah, people are still wearing the masks. A lot of our community travels to Riley County, which is Manhattan, Kansas, and there's a mask mandate there for most public spaces. So I think that's why we continue to see people using masks even here where it's not mandated.
Beth, is it mandated in McPherson?
Actually, it is mandated that they are requesting, but how do you enforce that? Most every business that is open, most of our businesses have remained open just with reduced hours, have a sign on the door that please, wear a mask when you come in. Once in a while, you'll go into a store where someone isn't, but the workers always are, and the majority of people are wearing masks.
And I like to continue to go back to the Colorado experience. One of their main industries is tourism. So you're looking at those ski areas. They have instituted a very good mask culture because they know that it's vital to their community and to their employers and their businesses. And so it has worked out very well for them. And again, the main thing about the masking is it does reduce your risk of getting COVID-19. So.
Yeah, I just got back from Breckenridge, and to your point, when you're walking into the community, they had signs posted that said, you're entering a mandated mask area. Yeah. And we got alerts on our phones one morning, just kind of like you would an Amber Alert. Mm-hmm. And it was to remind us that we were in a mask mandated area. Yeah. And that we needed to make sure we had our mask on. And they did have penalties and that kind of thing. But to your point, Beth, it really is probably hard to enforce it. But yes. Common sense?
I think a lot of our members are in the same situation that Austin is, where it hasn't been mandated by local government, but people in the community look to their healthcare providers as leaders, their hospitals, their physicians, and those communities are stepping up and saying, just as you are, masks are really important, and people are heeding that call. Yeah. We are certainly not traveling as a Care Collaborative team right now, but as we talk with our members, we're hearing a lot of that sort of sentiment of people are looking to us and asking those questions, which is really good to see all across the state.
Yeah. And even if there's not an individual or a mandate throughout, the individual businesses can certainly have that for their own business. And again, I think that's going to be the safest thing for their customers, for the community in general.
Yeah, that was a great question. Got another one?
Lisa asks, any thoughts on when people who are immunocompromised might resume some normal activities outside of the home? What type of benchmarks are you looking for?
Yeah. That's a very good question as well. I don't know. We know that the virus is here. We know that there are cases every day, and the running 7 and 14-day totals can be different. Last week we had a decrease in the running 7-day. This week we've kind of had slight increase compared to where it was. It is certainly much better than where it was a month ago, but this virus for the time being is going to be here. And so you have to first understand that knowledge. And with the understanding of that, understand what you can do to reduce your risk individually as much as possible. And that is going out when you need to. If you do have to go outside or go to a business or go to a restaurant, make sure that that restaurant is outdoors and you can do outdoors. We know that indoors certainly is a risk factor for catching it. Obviously, masking, hopefully everybody wherever you're going is masking. Again, the mask provides a barrier to people who may be sick and may be expressing the virus into the environment, but also can offer some protection to you, the wearer, as well. So doing those types of things, again, face shields and eye protection are always endorsed as well. And just understanding that the virus is out there and being safe when you do it, understand your own individual risk.
All right.
Sean asked Dr. Hawkinson, what is the status of new treatments for COVID?
So currently, new treatments, so antivirals, remdesivir is an antiviral. That is the only one that is currently approved. There are other companies working on antivirals. Obviously, it would be nice if we could get just an oral antiviral, something like Tamiflu that we could get when we're diagnosed. As of yet, there isn't that on the market, but there are a lot of companies looking at those types of antivirals. In addition, the convalescent plasma is still being utilized in a kind of emergency use authorization. We will begin giving that here again. But again, we don't know exactly, how sick you can be, how much the benefit is if you're very sick. And of course, it's probably better early on in the disease state. And again, as far as vaccinations, we know that there are 20 or more vaccine studies going on and being looked at. So that is it right now. There are no other new treatments. There are other trials of things such as immunosuppressive type drugs, things that we tamp down or decrease the immune dysregulation. Those drugs are already marketed for other types of illnesses and chronic conditions, but they are being trialed for COVID-19 as well, because a lot of the damage that is done in COVID-19 is, again, that immune dysregulation type of process after the initial viral infection. So there are those continuing trials that are going on, but as of yet, there's nothing new other than remdesivir, convalescent plasma, anticoagulation or the blood thinner, and of course the dexamethasone, the steroid.
I got to tell you how ignorant I am. What Beth just shocked me when she said, we just now got remdesivir. I mean, I would think that these drugs would be available to everybody everywhere.
Yeah, it's certainly getting better. The government originally took all of that and then distributed it to the states and had the states distribute it. Now it's all through I think a third-party distributor from Gilead, but now it's being it's rolled out to more communities.
Austin, do you have access to both?
We don't have access yet. I think they're basing it on allocation and caseload and positive cases within your county. So we're still waiting for our supply and haven't been able to order it through our GPO.
And Beth, I guess now that you've just gotten it and you told us a great story of how it was helpful and timely, it must be tough deciding what are the criteria for when you offer it now?
Dr. Stites could probably tell you more exactly what the criteria is. But if we are a small rural hospital, we don't have a pulmonologist on staff. We don't have an intensivist. We have great internal med hospitalists that do a great job handling these COVID patients. But we always ask ourselves, if this was our loved one, do we want to take care of them here in our ICU, or should we transfer them to a larger tertiary facility where they have things like the plasma, remdesivir? So before we had remdesivir, if there was anyone that needed intubation, we would intubate and ship. So if they needed remdesivir, they got it because we shipped them to another facility. But the last few weeks, we've been able to provide it here.
I think to be fair, the remdesivir in combination with, I think, the two more important components of this treatment algorithm and concoction is going to be that anticoagulation and the dexamethasone, the steroid. The remdesivir is definitely not a panacea. It's not a silver bullet. It is a pretty good drug, but it needs to be in combination with those other things as well, which I feel are probably more important. But as we move through this, hopefully we will get more potent antiviral medicines such as remdesivir.
Let's take a couple more.
So John has kind of a vaccine culture question. With the push from the government to get vaccines approved next month, how will the public in different parts of the state and here be confident that it is safe and effective before it's released?
Mm-hmm. Yeah, I think we have seen a lot of news recently about the government stepping in and giving their opinion to the scientists and the medical and the public health professionals. We know that the groups that are working on the vaccines, that are creating the vaccines, have signed a collaborative agreement to really work through the science, because that is going to be the most important thing. Working through the science, showing transparency, showing the data about safety and efficacy. And to be fair, we have certainly sped up the process of the vaccines. They do look safe. So far, everything we show does look safe. But we need to make sure that we complete these trials or get as far into the trials as we can to show further safety and efficacy. Luckily, all of these companies have signed that collaborative to do that, and they want to do it because it's in their best interest to do that. It is in their best interest to show safety and efficacy. So I think hopefully moving forward, there will be that information that is available to the public so they can see that it is safe. Because we do know that there is a anti-vaccination voice out there that is, fairly loud. And we don't want to do anything to harm our chances of giving vaccines in the future. So this is a huge step to make sure that it is transparent, that they do show all of their data for safety and for efficacy, because there are going to be the need for more vaccines other than this one. And we know that we continue to have our childhood vaccines, our adult vaccines as well, and everybody needs to get those to help prevent these easily preventable diseases.
Okay, so this viewer has a question about long haulers. Can the doctors discuss a little bit more about the idea that patients with COVID would experience long-term effects after they've been infected?
Yeah, so we certainly know, that has been the jargon associated with people who continue to have symptoms after having infection with SARS-CoV-2 or having COVID-19. That's the long haulers. We know that from studies that people can have symptoms for 30 days, 60 days, maybe even longer, especially if you had more critical illness and were in the ICU, you were intubated. Those symptoms can range, and a lot of this is going to be individual. I've seen patients who 3 months later still had a little bit of cough or had some fatigue. Those symptoms will range and be different from individual to individual. I think more common ones do include fatigue, cough, maybe shortness of breath. Those would seem to me the more common ones. The loss of taste or smell will come back gradually. It really does boil down to the individual. We don't know exactly how long that will last, but we do know it can last 2 to 3 months at least. Hopefully it will get better, but we just don't know how long. And we are developing a program or some verbiage here at the health system, especially with our outpatient primary care physicians, on how to best manage these people. There aren't treatments. A lot of this manage is going to be supportive care and symptomatic treatment for these things. And again, the most important thing is probably time.
All right. I think what we're going to do now is go to our guests and ask for some final thoughts and wrap up today's update. It's been a lot of great information. Austin, I'll start with you. Final thoughts?
We just really appreciate the Care Collaborative and everything the University of Kansas Health System has done for all of our rural hospitals in the state of Kansas, and I'm sure beyond, from just knowing what the proper PPE is to wear so we don't have to do all this research to which patients to put into which isolation rooms. So again, thank you to Dr. Hawkinson, Jill, and Jodi for making this possible for all of our rural citizens in rural Kansas. It's a big deal, so thank you.
Feel too. We appreciate you as well. Beth?
I guess I'm just so appreciative that we joined the Care Collaborative in January. We had a boot camp that was well attended, and we worked on the very same things that is being worked on throughout Kansas, the chest pain, the MI, the sepsis, the stroke. And so we had established a relationship with the KU Collaborative. And it was so reassuring to know that, they're just a phone call away or an email away, and you get immediate response and you get best practice and evidence-based medicine. And just to know that you're practicing in that arena, that as a small rural facility in small cities, there's no reason that our farmers, our rural people shouldn't have access to the same health care that people in large cities have. And I think KU has certainly brought that to our facility.
Thank you so much, Beth. That was really kind, and it is the way it's supposed to be, I think. And Jodi, I was going to give you an opportunity, and then we'll talk about tomorrow. What are your final thoughts?
I think I would echo what Austin and Beth said, is that we have this opportunity to share the great expertise of folks like Dr. Hawkinson and the entire team here. As we continue to go through this process, we're still learning more. There'll still be more information on vaccines and the long-term care for these patients, and we're still working with long-term care facilities on receiving patients. This is a long haul, and the more that we can be a resource, we really appreciate that, because our goal is to help improve the health of Kansans all over the state, and that's really the commitment that we're trying to live by through the Care Collaborative.
Well, Jodi, you're doing God's work. Thank you for being on. Tomorrow, we are going to be back to answer your questions. I have every reason to believe that Dr. Stites will be back and sitting here, and with him will be Amanda Gartner. We're also have a last-minute ad, too. We're going to add Dr. Heather Harris from Hayes Med. She's going to join us and talk about COVID in and around Hayes, and we are going to start giving the patient numbers at that health system as well, or that part of the health system as well. So we know that it will be a good opportunity. We also want you to know that tomorrow is the last day to send us your list of 50 reasons to love your mask. You can send them to the same place as your mask-wearing pictures. We got this photo submitted by Elena. It was taken in 2018. She said her husband was battling cancer. She writes, he's a 3-time cancer survivor. We wore masks before it was even cool. Masking is automatic now to keep everyone safe, just like then. And Jennifer, she sent this picture in. She says she masks so that she can spend time with her grandson. And up in the Northland, Library Lauren sent us this picture. She said, I wear my mask to protect my friends, my loved ones, and my customers. So those are great. I don't have any wonderful words to wrap up the show like Dr. Stites might have. So what I want to say is thank you to the community and to the media that show up every day with questions. We will stay here and answer the questions as long as you have them. So thank you for being with us. Dr. Stites is back tomorrow with Dr. Hawkinson. In the meantime, have a great day.